And we have to finish a lot of skill section. I will be starting on medication administration. After the med section, if you will go on your packages, 48 was medication, and then we did already in the separate package, was loose package 48, 49, 51. We have done 52, 53, and 54 is the medication. In some packages you may have on page 36, because 35 you're finishing the pain medication. And remember, I said we must know the medication. How do we give heparin? Tell me, how do we give heparin?
Sub-Q.
Sub-Q and IM?
No.
No IM. How do we give heparin?
IV.
Sub-Q and IV. Where can you give IV heparin? When you have patient with pulmonary embolism, MI, they can use it, and that is heparin can be given to the patient. Fragment. What is fragment is? What is fragment? Medication, and where do we use fragment? That's a blood thinner. You give them sub-Q, okay? Make sure you guys start memorizing. And Lovanax, you give them sub-Q. If the doctor has ordered fragment to give IV, and they give you the dosage, what is your responsibility would be, fragment, that we don't give IV? You only give sub-Q, because you've got to know that. And if they throw that question that you give IV fragment, your answer would be you question the doctor, because you don't give fragment IV. What is Colzar medication? Colzar. What is Colzar medication is? It's an antihypertensive medication. I'm reviewing, so that means we are not memorizing, and I want you guys every word to word. Don't wait for the last day. As we are moving in, I'm advising you. I know you guys have done a lot of things, but this is very important that you guys know. Okay, Colzar, what is in Colzar I said? That's an antihypertensive medication. You have it in the package, so make sure when you know by heart. Colzar is antihypertensive medication. There are two side effects. We wrote it down there, hypertension and fatigue. So make sure you guys know that. Thrombolytic medication. The word on thrombolytic medication means is what? It dissolves the clot. And what is the thrombolytic medication? I said we all should know is streptokinase. What is the medication is? Streptokinase. And morphine you're giving for pain, and what do you monitor when you give morphine? You all know that. You're monitoring for blood pressure or respiration. Morphine. Morphine depresses respiration. And that's why I said what antidote do you give for morphine is Narcan. Remember that word is Narcan. So make sure we all know. And all your depressant medication, it does cause constipation. I'll tell you, I've done some question. I came across morphine, there was not side effect, was respiration. Side effect was constipation. When you're giving too long, that all your depressant medication can lead to constipation. Narcan, I talked about that. What is Narcan is, streptokinase, and eye medication, Timoptic, pilocarpine, make sure you guys know. Timolol word, Timoptic, and what is pilocarpine does? That's a glaucoma medication. And what does it help them to lower the pressure? Now, what I wanted to see how far we are remembering. And I want you guys make sure we have done. Now, when you take the test and say, oh, I don't remember she did anything on these, but I'll tell you, believe me, if you will memorize, it will be very helpful to you guys. Now, next thing I wanted to know, what are the complications of amputation patient are? What are the complications are? Pain, yes, very good. And what kind of pain patient has?
Phantom pain.
Phantom pain. What is another complication is there? Hemorrhage. And what do we keep in the room? Was tourniquet. And for pain, I said, what do we use for pain? What do we use for pain? For amputation? Tense unit. I want everyone to memorize what is tense unit is. What is tense unit? Is blocking the pain center. And we have done that. And what is blocking the pain center? That means you do not use the medication. It's a non-therapeutic treatment. What is the meaning non-therapeutic? No drugs inside. So when there is a question, what do you give non-therapeutic and how does the tense unit work for pain management? How does it work? It blocks the pain center so you do not feel, a patient doesn't feel the pain. What is the third complication for amputation patients are? They're diabetic. So what would be the problem with diabetic patients would be? The wound healing problem, right? Because what happened? Healing process is very slow because they are diabetic, poor circulation. All your diabetic patients, think about, I'll tell you guys, the questions are not going to be straight. You've got to look around to see what they're talking about it. And if you have a good knowledge, you'll be able to pick up the answer. So everyone is okay, amputation tense unit. And what is the position we said for amputation patients are? Prone position. First 24 hours you elevate. After 24 hours you put them in prone position. Which are the three, everyone I want to remember with prone position are. What are the three conditions I told you? Number one, remember amputation patient. Number two, I said tonsillectomy. What else we said? Any other one we said?
Oh, cleft lip.
Cleft lip babies or cleft palate. Cleft lip you keep them on the back, but cleft palate babies you put them on the stomach and preventing aspiration. What position do you go if a patient is having seizure? What position do you? Sideline, lateral. Why? To prevent aspiration. Same thing. And why do we put on amputation patients on the stomach? Why do we put them on the stomach? To prevent what? Flexion word. Remember the word flexion. What is the meaning flexion? Going backward. See what happened? They have no legs. If you elevate them, what will happen? They're going to be, what is this? This is flexion. So the legs are going more backward. You don't want them. What do you want here? Preventing. What are you preventing? Flexion. What are we preventing in hip surgery patient? What are we preventing? Adduction. And what are we doing here? Abduction. What are we preventing? And what do you help patient for knee surgery? We are using, remember the word was CPM machine. And what is CPM machine does? What does it help them? Give them exercise. So what is the word I said? To give them what? Flexion word. Why? Because they won't be able to go backward. So flexion to improve their flexion. And what is CPM machine is? Continuous passive motion. Everyone need to know your COSAR word, medication, and your fractures, you must know. What do you prevent patient with fractures? What do we prevent patient who has fractures? Fat, remember, fat embolism. What is fat embolism does here? What is fat embolism does? Cause, remember, we said pulmonary embolism. And what is pulmonary embolism comes from fracture here. And when we do, patient has a fracture, the risk for two major complications in your question. We got to remember that. Number one is fat embolism, and number two, I said osteomyelitis. And how do you prevent these? This one, you clean the wound, and this one, immobilize your patient. Are we clear? So what do we do here? Immobilize your patient. So All right, let's go ahead and start. And I like you guys to go home early, but just think, we are coming back after lunch, and as soon as I'm done, I will let you guys go home, all right? So let's just be patient and make sure this class should be productive. Productivity will be only when you guys will study, and you will have to go back home, and I'm telling you to study. I know we are excited tomorrow, but if you're not taking till Monday, all the time just review everything, okay? And I will see, first I want to finish the all material, then afterwards I like to go over the answers we left over, and maybe a little bit review, but let's move on now. And remember the word I ended up, and let me finish that. What do you prevent on your patient with fracture question? And I said, first thing is, remember what is first problem with the patient is pulmonary embolism. If your patient fell, what would be the first thing you will do? I said, immobilize your patient. Are we clear? Immobilize means they're not going to move. If they're moving, then the clot is going to go all the way and lead to what? Pulmonary embolism. Second question, I said, if you have abrasion wound and if you have compound fracture, what would you do for your patient here? Cleaning the wound is important. And what are you preventing here? Osteomyelitis. Everyone is okay? Very important. Wherever you see abrasion, abrasion is going to cause infection. And first thing, you always clean the wound wherever we are. Tetanus is common, infection is common. And that's why cleaning of the area, even you have a plain water and soap, wash the area. So now I will move on to the next section, and I'm going to start with on your questions with pain management. We did the drugs and pain management questions. You guys go on your page 35 and 54, two different packages some of you have. And so what is pain management is, number one, is remember in your sleep question, I said yesterday, I want definitely everyone remember, I was talking about sleep, and I'm repeating again here. If patient is not able to sleep, what do we give them? First is relaxation technique. Do not ever pick up straight for pain pill medication, sleeping medication, right away. If it is too easy answer, if you think they're saying patient is in pain, what do? Give pain medication. Are we clear? That's not the right answer. Patient is not able to sleep, and if you say, call the doctor, get a sleeping pill, that's not the right answer. What do? Maybe you have relaxation technique. And I said, if the question says, patient has been doing relaxation technique, what do you do now? Ask them how they have been doing it. Why? Because sometimes patients are telling you, but how do they really are relaxing and what is their routine is. So before you teach patient, what do you need to know? What do you need to know? What they really know about the procedure, or what they really have the knowledge. So I will move on pain management question. On pain management, number one, you have patient control analgesic pump. Everyone knows for pain, we have patient with what? PCA pump. And number two, I want everyone knows the TENS unit. And what is in the TENS unit, we said here, is the patient with PCA pump. What is a PCA pump? Patient is controlling. Which patient do we use PCA pump? When they have really a bad pain and they're not waiting for the nurse to come and give the medication. But what is your responsibility in your question when you have a patient with PCA pump? What is our responsibility? I want everyone right down there is count the dosage. You got to know how much patient is using in your time. Even patient is using, and they may throw the question, then you are going home. And it's time for you to go home. That means your shift is over, finished. And your oncoming nurse is coming. Patient is on PCA pump. What would you do? You give report. Are you going to give report? Yes. And what would you count that how many doses patient has used? Remember, any medication, you keep it in the room or patient is administering themselves, your job doesn't go away. Your job is still there. And what is your job is there? To count the dosage. Make sure patient is taking correctly. How many doses are left? Everyone is okay? Patient is on PCA pump and you're going home and you have oncoming shift nurse. What would you be doing? Counting the doses and see how many doses when you came in patient had, how many doses patient has taken. I know there won't be any side effect. Patient is very safe to use it, but your job is to do assessment. Are we clear? Number 2, rating scale. What is in rating scale means is here, is you must check the patient, what is the scale on the pain. Some of you may have a little different, but you do have PCA pump, then you have pain rating scale. What is the rating scale? Pain scale. What is the pain scale? 0 to 10, right? What is your pain scale? Page 54 or page maybe 36. So 54 where we started after the medication, and on pain medication I'm on, pain management. Under pain management we said PCA pump. Number 2, I said rating scale. The rating scale, how do you assess your patient pain? Is number 2 is, remember, the word is the scale you have. What is another way of assessing your pain? What is another way to assess pain? Facial, yes. And remember your question. Somebody cannot speak language. They are not comfortable. Culture question. Remember, we are all multicultural people are. And your patients the same way. So a lot of question. Person culture, they don't speak about the pain, but how do you assess them? By their look, how is their face, how they are acting, and non-verbal, verbal and non-verbal communication. Child question. Child is not able to tell you about the pain. How do you assess? Same by non-verbal communication. So don't forget those two. We already know that, but you got to attach your question. And what do you check on your pain? What are you asking before you give patient medication about pain? Patient says, I'm having a pain. Do you just go ahead and give pain medication? No. We have learned you assess, and what do we assess? Where is the pain? Do we ask that? Yes. Now, if you have a pain medication only for hip pain, and now patient is saying, I'm having severe headache. That's a different thing. Can you give the same pill which you have an order for hip pain for headache? No, because it does not specify. Yes, if you have an order generalized pain, that's okay. You can give because it's generalized pain. But remember, if you have an order for one pain, you do not move to any question if patient does not have that pain. What do you ask in pain assessment? What do we ask in pain? Where is the pain? How does the pain started? How does the pain relieve? What do you do when your pain is intensity of the pain? Duration. These wordings are going to be there. And if you don't pick up those answers, will not be right. Because we have learned. What are we assessing is, you don't ask what pain pill have they taken last time. That's not important. What did they eat before they had a pain? No, that's not important. What is it important before you give pain pill is, where is the pain? The pain duration, intensity, how bad, how does the pain started? So remember, before you pick up any answer, we have really very high on pain assessment. So you know how to assess your pain rating scale, assessment of pain. And we did yesterday one question. Patient came back from Turk and patient has a pain. And before you give pain medication, what were you going to check? The answer was check the tubing. Why? Because maybe the tubing is blocked and causing pain. Now, pain is triggered because of the tubing. So what are you going to correct? Before even you give pain pill, correct the tubing. Are we clear? So make sure you guys do not pick up your answer without reading and look at what else can you do. What are they addressing? Are they addressing patient has mastectomy and patient is having a pain? Where do I go and assess the pain? Do I look at the drainage? Do I look at the dressing? Anything is there. So look into that. Tense unit, I want you to highlight the word intense unit. Chronic pain, you can give them for chronic pain patient. Those patients are taking regular medication all the time. Patient has chronic pain, you give them. Underline the word second line. If patient has pacemaker, then you cannot use tense unit because it will interfere with their pacemaker functioning. Anything electrically, you do not apply because patient has pacemaker. Now, what is the sign of pacemaker failure? What is the sign of pacemaker failure? What is the sign of pacemaker failure? Dizziness, number one answer. We have done that in cardiac. So, every line you guys have highlighted, you guys need to pay attention. Not thinking, I think, as we all know, no. If you don't, you have 15 side effects, but they're looking for the major one. And if you don't remember, then will be you're missing your question. Patient has your pacemaker failure. First sign is dizziness. Yes, if the heart is not working, you will have cardiac dysarrhythmia, but that would be later. Patients start, your cardiac is failing, they start feeling dizziness, weight gain, and headache. So, tense unit is, everyone need to memorize that, is for, you use for patient with phantom pain, chronic pain, and if patient has cardiac problem and they had a pacemaker, you may not use it because it will interfere. Third line, the next line, tense stimulate endorphin production. Highlight that. And last word, close the gate. That is important. What is tense unit does? Closing the pain gate. Everyone is okay? Tense unit is closing the pain gate, and you are using, and they're putting it on the skin. It is a stimulating the nerve, and you do not use if patient has. Now also, I want you to add, and some of you may not have, what is another thing you do to relieve the pain? Now, first thing, we already said assessment for pain question. What else can you do to relieve pain? Just like for sleeping, relaxation. What do you do for patient who is in pain? Comfort measure, positioning, back rub, maybe your answer. Before you give your patient pain pill, what do? Maybe make sure patient position, reposition the patient. Maybe the answer make him comfortable. Maybe the position is not right. Patient is not comfortable. He's laying or she's laying on a wet sheet. You got to change those linen. That is causing pain. And remember, a lot of time back rub. Nowadays we don't like to do back rub. And I'll tell you, sometimes the nurses will tell, I'm not the massager, we don't do the back rub. But when I was the CNA and I was the LVN, we used to do every night. And I'll tell you, that's many, many years ago. And we used to do all the back rub. That was one of our jobs before patient is going to go on the bed. And we had lotion we apply, we turn them, change the linen, give them the bedpan before they're going to sleep. Why? Comfort measure. If you don't give comfort, now what are we doing? We become so much mechanically, patient has pain, okay, what is the pain? Give medication. Are you depressed? We give you the medication. So what do we deal with? We forgot totally is our basic nursing care. And that is the basic nursing care is make your patient comfortable. Is there any other ways before medication you try to go back? So we are going back some of our basic, and that's why they're adding a lot of questions on your basic care. So I gave you some ideas. So on your pain question, how do you assess? Do not pick up right first answer, give pain medication. Do not pick up first answer to give sleeping pill. See, how do you make your patient comfortable? Next is medication administration. And I want that is to document and all that I will talk later. But how do you give medication? You guys have all on your packages. You all know right medication, right patient, right time, right dose, and right patient. If they give you a question, patient has no name band. What do you do if you have no name band? What do we check? ID band. A lot of places you may not have the pictures. Some places may have, because now with all legalities, you can't have post everybody's pictures. Maybe ID band, you must identify. Even you are working there for 2 months and you know your patient. But if someone is observing you, you're giving medication, and you do not check the name band, you will be written up on that. So the reason is you got to identify your patient and be in habit. Don't become, oh, I already know and I'm not even checking. Yes, we must see they have a ID band. If patient doesn't have ID band, do not pick up answer to get a new ID band. It will take for longer time. You got to call, they have to print out, they have to send it. But what can you do? Somebody who is working, they know the patient, have double checkup by recognizing by your CNA or somebody else. That may be your best, closest answer. The next thing I want you, where it says right medication. Another thing I want everyone to remember is physician signature. Before we are giving medication and you're starting a new medication, make sure you have doctor's order. Physician signature is very important. And you have not seen even that order have been ordered by the physician. Doctor came in, he wrote the order, but he did not sign it. It doesn't get valid unless what? The physician has signed the order. In your question, telephone order. You get telephone order from the doctor. And in your question, it says the telephone order has not been signed. What do you do? What do you do now? Renew the order. You cannot use that same telephone order. We have policy. In your policy, you must sign. That order must be signed out by the physician. So I'm under medication administration, rights of medication. What are the rights of? Right patient, right medication. And when you're giving medication, they may not throw the wording same way like this. They might throw the wording, your telephone order is not signed. Can you give that medication? No. Why? Because you need to have the physician verified, and if you don't have, then you call the doctor. If you're not clear with the order, your dosage are not correct, your route is not correct, you question the doctor. And that is what coming all in your exam, even NCLEX, they're not giving a straight question, this is the medication, what do you do? We just give the medication. They're asking you what medication would be given if you have this patient, and what would be the symptom. So for now, exam, at least we all must know, the physician must sign the order. When you're giving, make sure you have a doctor's order. If you don't have a doctor's order and you have some medication, I'll tell you, it happens many times. That medication was ordered 7 months ago, and somehow that medication is still in the cart or came out from the pharmacy. And you have no order. And I have seen a lot of time people will give that medication. But what are you not looking? Your doctor's order. So remember, doctor's order is important. Question on telephone order is not signed. What do? Renew the telephone order. Right dose, right patient. That's important, that we all know. And the next thing is documentation. Everyone knows after you finish your procedure, what do? Document. Documentation. You haven't done, you haven't signed, you have not done. You gave medication, you go home, and you didn't sign. What does it mean? You did not give that medication. Do you go back after 1 week to sign that med book? No. That's very not acceptable. Anything, I will talk about it when you sign that, is late entry. Late entry means you did not sign on the time. Is acceptable, but only once a while. Not every day you go back and sign late entry. It shows how nurse you are. You're not finishing your timely work. Next is documentation is important. And remember, correct information. Do not write something you have not done it. And that's important. Does patient has right to refuse medication? Yes. Then what do you do if patient refuses the medication? Document and ask why, and also notify your physician. Make sure we must notify. It's okay one time today your patient refused it, you go back second day, you go back third day, now today is 2 weeks. Patient is refusing his Accutech. Patient is refusing his insulin. Wouldn't you let the doctor know? Yes. Because what happened to the patient? Something happened, family member. Would you let the family member know? Whoever is responsible? Yes. Because what happened? Family member can come back after 4 weeks when patient is admitted in coma and said, I never knew my brother was refusing this medication. Nobody called me. Then we get in the fault. Yes, it's important that we notify patient refuse. You guys are good. Ask them why. And they're refusing. Yes. Nowadays is not a reason we should force it. We do not force it. Ask them why, document, and notify. Medication error. When you have medication error, what do you need to fill it out? Incident report. What do you fill it out? Incident report. I will be talking about incident, but what is incident? Any unusual thing happens. You give a wrong medication. Is that a routine for us? No. So what do? Notify doctor and notify is the family member. Patient must be aware you did a wrong mistake, and document and assess. But what do you do the first thing? I want you to highlight the word assess the patient. What do we do here? Assess the patient. Now there may be answer. You gave a wrong medication or your patient fell. What do you do the first thing? Fill out incident report or assess or stay with your patient? That would be your best answer. What do we do first thing? Stay with your patient, assess your patient, then later we are going to fill it out. See, all the answers are correct. They're asking the priority. So a patient, you gave a wrong medication, assess your patient. What are we assessing? Patient's response is also their alert oriented, and what are you monitoring? Their vital sign. Then later on, yes, you fill out the incident report. Now in the same line, you guys have home medication. Now if you have a question, so that's a different thing. You have a patient, you give a wrong medication, what do? Assess your patient first. And then what do we do here? Fill out the incident report. Second thing, if you have a patient and you're working like in a nursing home, and they bring the medication from home, long-term care patient, what would you do? Remember, your questions are going to be a lot of geriatric question, nursing home question, and what would you be doing for your patient when they bring the medication? What do you do if your family member and patient brought a whole big sack of the drugs? Can you use them? Why not? Why not? Now, let me tell you, these days, once you are paid for those medications, Medicare, insurance company, it's already in the computer. If you're going to order again, it will reject it. Why? Because they already paid for 30 days and 90 days supply. They're not even giving 30 days. You save a little bit more money when you're getting for 3 months supply. So they have for 90 days supply. And they may not be able to get it. If there is something new, yes, they will be able to get it. But how do we do it? We all have a policy. And see, these kind of questions, we will see it, and that's why I'm going over. Any patient brings the medication, yes, what would be the best is review the medication. Make a list of the medication with your RN and then verify with the doctors. Now, what do we usually do? A patient is on Lasix, 40 milligram, patient was at home, Lasix, 40 milligram, I can use this medication. But what do you want to be sure that these pills are safe? Now we have those packages, bubble packages, but you do have patients who come back in the bottle, those pills are. Now, bottle can be easily, and a lot of time what happens is they mix the pills. They have different colors pill, and then you have a doubt, can you use those medication? So what is legality says here? We all have policy, medication must be verified by the doctor and by the pharmacist. Everyone is okay? So what do you do as a nurse if the family brings the medication here? Register all your medication. Write it down. What the family member brought the pills. And then you verify, write down from the physician and the pharmacy. What the pharmacist will do, they will initial, we can send them to the pharmacy, and pharmacy will send it back to us by saying, verify these medications are safe, then you are safe. Are we clear? Anywhere you feel it doesn't look good, let the pharmacist, let the doctor know, you may have to discard that medication. Now what do? The family brought 20 boxes here. You can only use maybe few medication. A lot of time what happens, you keep all that old drug and prescription, and when you're going home or hospital, you pick up some of the medication. You have never used it, but they brought it, and you don't need them. What do you do if you don't need those medication? Return them to the family member and have them sign. Why? Because many times family member will come back. I had many time experience, and I would save all the drugs. And all the drugs, when I save it, and I know after 2 weeks, patient died, family member came back. My dad had a lot of insulin syringes. My dad had so much of supply of this. I want to take it back. That's my property. And you got to return that back. And if I don't keep that record, what will happen? I'm making family member very unhappy. So what I do? You got to return the medication. So in your question, let's go back as a question. As what do you do as a nurse? Your patient brought the medication from home. Make a list what they brought it. Make a list what you have used it. Verified from the doctors. What you have not used it, give back to the family member who brought in and have them sign. And you put them in the chart. You have every single pill are counted. And I'll tell you, we all know if people don't give medication, if you do borrow from somebody else, never make habit, because you cannot borrow any medication from one patient to another patient. So remember, on your questions are, what do you do, incident report or patient fell? Assess your patient first. Then you do fill out incident report. Patient bring the medication from home, review all the drugs, send it back, what you don't need it. Verbal prescription. Can you take a verbal prescription? There is a difference between verbal and telephone. Verbal means the doctor is right there. Why would you take a verbal prescription when doctor is there? He should write it down if he is in the building. So what is the meaning is here, don't accept verbal prescription. It can cause mistake. If you have called the doctor for some reason, the doctor returning your call back for your lab and he gave order, we call the telephone order. Verbal order, I had at one time the doctor who was in the building, and he said to the nurse, I'm making my round and I want you to go ahead and write these orders for me. And the nurse was good. She called me and asked me, can I write this order? I said, no. The doctor need to write down those medication. He is in the building. Why he's not writing and why he's giving you? You have other things to do. First thing, that's his responsibility to complete. So remember, verbal prescription, a lot of things doctors comes in and tell you to do that. Do you follow what they're telling you? No. What do you follow? Your scope of practice. What is your scope of practice? You can take the telephone order, but not the verbal order. Doctors should be here, doctors should write it down, it can lead to mistake. And ensure doctor's order, telephone order is okay, and make sure the doctor sign all your orders. Doctor came in, he wrote the order, he forgot to sign it, make sure have them sign it. And make sure you can read their orders. Make sure you understand clearly what you're going to do it. And those kind of questions would be there. So everyone knows home medication. When you get doctor's order, telephone order is okay, verbal orders are not there. And before you do patient file, what do you do? Assessment. Now I will move on, medication via tube feeding. How do you give your medication via tube feeding? You have patient NG2 and G2. All your questions, read it good. You can give your medication. What do you avoid? I said earlier, enteric-coated medication. You must change the order, get in the liquid form. And what do you do before you give your medication? Your patient is NPO. You're going to give medication. Even your patient is on tube feeding. What do you check first thing? Placement. Everyone is okay. What do you check first thing? Check for tube placement. And then what do you do once the tube is, you checked it? These are your question, skills, NCLEX, HESI, everyone should know. Check the placement. And flush the tube. So you clamp it after you check it. And make sure your all your liquids are ready. And you unclamp afterwards. And then before you are going to give you flush before and after. And give them by gravity. Everyone is okay? Check the placement. Flushing, maybe 20 to 50 ml before and after you must flush. And what did I said earlier the other day? Do not connect with suction machine. Why? If patient has suction, what will happen? All the medication will be going out. So even you're feeding or you're going to start after medication, always clamp it for 30 minutes and then you continue with suction or feeding. Everyone should know your procedure. I'm going over highlighted and there would be answers so close that if you are not clear, you won't be able to pick up the best answer. Rectal suppository position. What is the positions is called left side position, Sims position. And some question would be, what do you do first thing before you give suppository? I want you to add there is soften the suppository. What is the meaning soften? Because suppositories are in the fridge. And when you're taking it out, it's very hard. You can lubricate, but let it stay for a while outside before you insert. And you can also lubricate. So soften and lubricate is important. When you're inserting, what do you teach patient? Take a deep breath and insert the suppository and hold it. Any ointment. Ointment, I mentioned on a burn question. You wash it the skin with normal saline before you apply. But you can have is ointment is your nitroglycerin ointment. Nitroglycerin is you're giving, how do we give nitroglycerin? You can give under the tongue, you can apply the ointment, and also they have a spray. You can also have in a spray. So when you're giving nitroglycerin, make sure non-hairy area and also clean the skin area, wash it non-hairy and apply it and use the gloves. Must use the gloves, especially for your nitro, all your ointment. But for nitro, you will absorb the medication. So you must wear the gloves and non-hairy area. In cream question, when you're using cream, we all know the cream can be our suppository. Also number 6, where it says cream, may be a vaginal cream, a vaginal suppository. Is, I want you in there, is wash the area and maybe if it is, and what is the best time for the female patient to give their vaginal suppository? In the night time. And that may be for your question. And what do you tell the patient? Go to the bathroom before you put it in, wash the area, and also after you put it in cream or suppository, leave the patient in supine, underline the word 15 to 30 minutes. If they didn't have 15 minutes and 30 minutes, that's okay. Is lay patient. That means if they're going bathroom, they're going to lose that medication. Eye drops question. Where do you put the eye drops? Are in conjunctival sac. In the lower conjunctival sac, you put in the eye. And what do you tell the patient? And you apply the pressure. Now remember, why do you apply the pressure on the eye, and where do you apply the pressure? Inner canthus. Where is the inner canthus? Close to the eye. And why do you apply the pressure? I want you to add the word systemic absorption. The word is systemic absorption. How do you prevent systemic absorption? Means is you are applying the pressure. What happened? You put the eye drops. Eye drops is in the eye, but it can affect blood pressure, breathing problem, and some medication like your beta blockers can affect the blood pressure. Right away the blood pressure can low. So question, you're putting eye drops. How do you prevent systemic absorption? Applying the pressure. Why? It stops absorbing too quickly in the system. That's the reason. So apply the pressure. Ointment. When you're putting ointment, you squeeze the ointment. I would say it says lower conjunctival, but also is good when you're putting ointment. Where do you go? From inner to outer canthus. So where do you go? Inner to outer canthus. So put down on the eye ointment. Optic is ear. We all know ear. Any question, ear drop. Keep at the room temperature. Where do you keep eye and ear medication? You have in the med card. But remember, is separating them. Don't put mixed together, because we can make the mistake. We can use eye drop for ear, ear drop for eye drop. And so separate them, never keep mixed up, and room temperature. And that highlight that word. Older adult and children more than 3 years, what do? You pull the ear upward and backward. Under 3 years, what do? Pull downward and backward. So make sure you all know how to put your eardrops. You're pulling backward for the small children. And remain them. What do you do after you put the eardrops? Keep that position. Let it absorb. And lot of question. If patient, after you put eardrop, and patient feel dizziness and headache, that means they might say your temperature of the eardrops may be too cold or too hot. And that may lead to dizziness. Nasal drop. When you're putting in the nose, what is the best position? Is first thing, what do you do? They're not asking what is the nasal drop. What do you do? The first thing. Underline the word wipe with the tissue. Why? Why do you wipe with the tissue? Because your nose, patient nose must be clean. If you have a lot of, is the mucus in there, it's not going to take absorption. Not even you read, you extend, they're saying, what is the first thing you do before you put nose drop? Clean the nose or wipe the nose. And then what do? You put the nasal drop, and what is the position is? Underline the word hyper extended. You got to put the head backward, extended. So hyper extended, wiping, 2 word is important here. Inhaler word. When you're giving inhaler, there are 2 kinds of inhaler. One is without the spacer, and the other one is with spacer. So without spacer, keep away from the mouth. That means 1/2 to 1 inch. And also open the mouth, don't let it touch inside the pharynx. Then you will go, is if there is with a spacer, they can put in the mouth. And what do you tell the patient for inhaler? Pay attention, lot of teaching question. How would you teach a patient to use inhaler? First thing is, you always remember, any medication, shake it. And then when you put it in, we already said, is you press it down, the inhaler. When they're pressing, very important word is, breathe in slowly. How do they breathe in? Slowly. Any teaching slowly work in a breathing exercise and also giving inhaler. What do you teach them? Breathe in slowly and deeply through the mouth. And afterwards, what they need to do. So underline the word breathe in slowly, and breathe in slowly and hold it for 10 seconds. Take your 2 to 3 seconds to take it in. After you take it in, you hold it. And then what do you do? The next thing, pursed lip breathing. Everyone remember pursed lip breathing is slowly you are exhaling through the mouth, and wait for 2 to 5 minutes between the puff. And if you have two puffs together, I said already what is the two puff you will use first? Bronchodilator, and then you will take the steroids. They can also use the word is MDI, and they may use the word is meter dose inhaler. It's the same thing, meter dose inhaler. So make sure you write down the wording on the side, MDI, meter dose inhaler. What do you tell the patient? You have two inhalers are there, is what do you tell them? Wait before you use the another inhaler. Which one do you use? First inhaler, bronchodilator, and then we are going to use the, your steroids inhaler. Let me finish 2 or 3, then we'll take a break. Sublingual medication is you give nitroglycerin under the tongue. Let it be dissolved under the tongue, and do not take water right away because it should dissolve. And sublingual is absorbed very fast. That's why you're giving nitroglycerin. Buccal goes between the gums and the cheek. Then you have number 15, parental one, is which is the good side is, underline the word, ventrogluteal side. Ventrogluteal side. The best position when you're giving ventrogluteal is the prone position, or also pointing the toes inward, sideline position, flexing the leg is flexing the upper leg. But everyone should know for IM injection, ventrogluteal is the good side. Now you guys all have done. Any question would be on your injection, needle side, sub-Q, IM. Next one, safe side for all patients. That's ventrogluteal is good. And in the children, what do we use here is the vastus lateral. And what is the vastus lateral is in the anterior lateral thigh. Highlight that word, anterior lateral thigh. And IM injection for the children would be vastus lateral. Then I want you to go into the next one to highlight the word deltoid muscle. Deltoid is in the arm. When you're giving deltoid, you skip all that, what we have written here, but highlight the word is deltoid. Deltoid is in the arm. And when do we use deltoid? You can use it for IM injection, but no more than 1 ml, because you don't have enough muscle. Deltoid, you can use it arm to give IM, but no more than 1 ml. Dorsogluteal muscle in the last, no longer recommended because it has a lot of nerve. So let's take a break and then we'll continue.